Today's topic is ptosis, functional anatomy, LPS or levator palpevi superioris muscle. How many muscles present in lid? How many muscles present in eyelid? Anyone? Stand up. हाँ तुम खड़े हो जाओ. मैंने तुमसे पीछे वाला, तेरे से पीछे वाला. How many muscles present in eyelid? LPS, orbiculus oculi, Muller's muscle. What are the actions of these muscles? Elevation of eyelid. इसका orbicular इसका closure of eyelid and Muller's का 1 से 2 millimeter elevation. Nerve supply of these muscles किसका? LPS. तू बता दे यार, खड़े के थर्ड किडनी नर्व किसका? LPS का. और मुलर्स का सेवन नर्व. वेरी गुड. मुलर्स का भी सिंपैथेटिक बता दिए किसी ने. गुड. सिट डाउन. LPS is the primary muscle responsible for lid elevation. It arises from the back of the orbit and extends forwards over the cone of the eye muscles. It inserts into the eyelid and the tarsal plate, a fibrous semicircular structure which gives the upper eyelid its shape. LPS is supplied by the superior division of third cranial nerve or oculomotor nerve. Second is the Muller's muscle. The way that LPS attached to the tarsal plate is modified by the Muller's muscle. This is the cut section of eyelid. You can see all three muscles, orbicularis, levator and Muller's. Frontalis and orbicularis oculi. Frontalis muscle and the orbicularis are both supplied by the facial nerve. Frontalis contraction helps to elevate the eyelid by acting indirectly on the surrounding soft tissues. Though it is not the primary muscle, but it may help also to elevate the lid. Frontalis muscle, while orbicularis oculi causes the closure of the eyelid. Ptosis means drooping or falling of the upper or lower eyelid. Classification: congenital or acquired. In acquired, it may be neurogenic, myogenic, aponeurotic, mechanical and neurotoxic. Congenital ptosis is associated with the congenital weakness or maldevelopment of the LPS muscle. It may be again 3 or 4 types. Simple congenital ptosis with associated weakness of superior rectus muscle, or blepharophimosis syndrome, which comprises congenital ptosis, telecanthus, epicanthus inversus and blepharophimosis. You'll see in this picture, telecanthus means increased distance between two medial canthi, epicanthus inversus, and it is a dominant inheritance, rare congenital disorder. Another type of the congenital ptosis is the congenital synkinetic ptosis. This condition is characterized by synkinesis, when two or more muscles that are independently innervated have either simultaneous or coordinated movements. Like in Marcus gun phenomena, stimulation of the trigeminal nerve by contraction of the pterygoid muscle of jaw result in the excitation of the branch of the oculomotor nerve. So when you have movement of jaw, there is simultaneously elevation of the upper lid. So there are two major groups of oculomotors and kinesis: external pterygoid and internal pterygoid. In external pterygoid, when the eyelid raises upon jaw thrust to the opposite side. In internal pterygoid, when the eyelid raises upon the clinching of the teeth. So these two actions also move the upper lid. So in this picture you will see there is ptosis of the left eyelid, but when the patient open the mouth and movement of jaw will causes elevation of lid and ptosis disappear. There is inverse Marcus gun phenomena in which synkinesia between cranial fifth and the levator more rarely causes the ptosis. Marie-Nemeth syndrome is a facial nerve aberrant innervation. Ptosis in Lambert-Eaton syndrome may temporarily improve after a brief period of upgaze. Eyelid myotonia may cause transient difficult opening the eyes after a forceful contraction or transient lid retraction after looking up. Blepharospasm is a focal dystonia causing involuntary eye closure. Then we come to acquired ptosis. Types are the neurogenic, myogenic, aponeurotic, mechanical or neurotoxic. In neurogenic, again Turner palsy, Turner misdirection or Horner syndrome. Neurogenic caused by the innervation defects such as the Turner palsy, Turner misdirection, Horner syndrome, ophthalmoplegic migraine, and cerebral ptosis. So right Turner misdirection, rare unilateral aberrant regeneration following acquired Turner palsy. Pupil is occasionally involved, bizarre movement of the upper lid accompanied by the eye movement. Horner syndrome, there are different etiology. In brainstem, central etiology is the brainstem disease like vascular or demyelination. Spinal cord disease like syringomyelia tumors. In preganglionic or second order neuron, there may be intrathoracic lesions, Pancoast tumor or aneurysm, and neck lesions. There is phenylephrine test to detect this Horner syndrome. Patient with minimal ptosis should have a phenylephrine test performed in the involved eye or eyes. 2.5% or 10% phenylephrine instilled, and in the affected eye, 2 drops are placed on the patient and re-examined after 5 minutes. And MRD1 means marginal reflex distance is rechecked in the affected and unaffected eye. If it is more than difference of 1.5 to 2 millimeter, that means test is positive. Other features of Horner syndrome are mild ptosis, meiosis, anhidrosis, ipsilateral loss of sweating, and mild anophthalmos. Another type of ptosis is the ophthalmoplegic migraine. It is a rare disorder previously called complicated migraine and also recognized as cranial neuralgia. This disorder most commonly present in early childhood or infancy. To date, there is no conclusive hypothesis and characterized by the severe headache, weakening of muscles around the eye, and these headaches commonly precede an episode of partial paralysis of third, fourth, or sixth cranial nerve. At least 2 attacks fulfilling the criteria, and migraine-like headache is accompanied or followed within 4 days of its onset by paralysis of one or more of the third, fourth, or sixth cranial nerves. Another type of neurogenic ptosis is cerebral ptosis. Due to the supranuclear lesions, unilateral occurs with lesions usually ischemic of the opposite hemisphere and more common with the right hemisphere lesion. Bilateral supranuclear ptosis may occur with unilateral or bilateral hemispheric lesion. Then this is the neurogenic. Then come to the second type of acquired ptosis, the myogenic ptosis. It is due to the acquired disorder of the LPS muscle or at the myoneural junction. Myoneural junction is the junction where nerve relays to the muscle. Myasthenia gravis, myotonic dystrophy, ocular myopathies, and oculopharyngeal muscular dystrophies. In myasthenia, it is frequently asymmetric and more common unilateral, though it will tend to shift from side to side, characteristically fluctuate from movement to movement, and is worsened by the prolonged upgaze. So it is called fatigable ptosis. Cogan lid twist sign is positive. Curtain sign or seesaw ptosis, when the ptosis is asymmetric, the driving discharges attempting to keep the more ptotic eyelid often are all transmitted as per Hering's law to the less ptotic eyelid. So manually raising the more ptotic lid causes relaxation, and the eye with less ptosis, sometimes even no ptosis, or may suddenly crack. Investigation in case of myasthenia is adrophonium test, electromyography to confirm the fatigueness, antibodies to acetylcholine receptors, and CT or MRI for presence of thymoma. Treatment: the medical anticholinergic steroids, azathioprine. In surgical, thymectomy is done. Another adrophonium test is the to inhibit the acetylcholinesterase, thereby prolonging the presence of acetylcholine at the neuromuscular junction, result in enhanced muscle strength. In ptosis, a positive test is the elevation of eyelid in 2 to 5 minutes post administration of tensilon. A negative response when there is no improvement within 3 minutes, and relative low sensitivity test, false positive result can also occur. So before injection there is ptosis in left side, and after injection you will see the lid is raised. In myotonic, release of grip difficult and facial weakness and ptosis is there. There are ocular myopathies, and come to the aponeurotic ptosis. It develops due to defect of the levator aponeurosis in the presence of normal functioning muscle. Muscle is normal, his power is normal, but there is defect in levator aponeurosis. It includes involutional or senile ptosis, post-operative ptosis due to the weakness associated with the blepharochalasis. These are a picture of aponeurotic ptosis. Causes are involutional, post-operative, and blepharochalasis. Senile or involutional ptosis is very common. Asymmetric lids and redundant lid tissue in the elderly. The levator aponeurosis attaches the levator muscle to the tarsal plate which form the eyelid. Aging may cause the levator dehiscence disinsertion, with stretching, thinning, or detachment of the aponeurosis, normally with the eyelid gently closed. So, this is the picture. Mechanical ptosis due to the excessive weight on the upper lid, due to lid tumors, multiple chalazion, lid edema, or cicatricial ptosis in cases post-burn or ocular pemphigoid. Case in this, there is large chalazion on the upper lid causing ptosis or dermatochalasis. Loosening of the skin of the lid may cause also ptosis. Neurotoxic ptosis by the bilateral, usually accompanied by the diplopia, dysphagia, or progressive muscular paralysis. Regardless, neurotoxic ptosis is a precursor to respiratory failure and eventual suffocation caused by the complete paralysis of thoracic diaphragm. Another type is the pseudotosis, when there is no ptosis but it appears like a ptosis. Appearance of ptosis in absence of levator abnormality. Exclude pseudotosis on inspection. Common causes are microphthalmos, anophthalmos, or anophthalmos. Blepharochalasis refer to the age-related lax, baggy skin around the eyelid. It can also simulate ptosis, but levator function is normal. There is Duane's syndrome. The palpebral fissure narrows on ocular adduction because of globe retraction causing dynamic inward movement of the eye. These are the causes of pseudotosis. Then how to evaluate the case of ptosis? To take the age of onset, will determine it is congenital or acquired, duration of ptosis, unilateral or bilateral, and diurnal variation. So in cases of myasthenia, ptosis increase at the time of evening. Associated history, diplopia will reveal the involvement of other extraocular muscles along with LPS. Associated with jaw movement in jaw winking synkinesis, abnormal ocular movements and abnormal head posture. History of trauma or previous surgery, poisoning, use of steroid drops, any reaction with anesthesia or bleeding tendency. In ocular examination, normal position of eyelid. So normally the upper lid cover the upper 1/6 of cornea or 2 millimeter from the limbus, while lower lid just touch the limbus. So if upper lid covering more than 2 millimeter of the cornea, that means it is a case of ptosis. So normal upper eyelid in primary position crosses the iris between the limbus and pupil, usually 1 to 2 mm below the limbus, and lower lid just touch the limbus. So we will see that it is unilateral or bilateral, complete or incomplete. Total unilateral ptosis in cases of complete Turner palsy, mild to moderate unilateral ptosis in cases of Horner syndrome or partial Turner palsy, mild to moderate bilateral ptosis. You see the head posture. In chin elevation as the ptosis minimum in down gaze in patient with congenital ptosis is also one of the indication of surgery, especially in the pediatric age group. In ptosis, there will be superior altitudinal defect, which is corrected by elevating the eyelid. Ocular motility importance in myogenic ptosis to rule out the thunder palsy, presence of strabismus, especially vertical, that corrected prior to the correction of ptosis. Visual acuity should be assessed and recorded. Then we will measure the marginal reflex distance, vertical fissure height, LPS action, lid crease level, and lid level on down gaze. These will help in surgery. What is marginal reflex distance? MRD1, when the light is thrown on the cornea, a reflection occurs, and the distance of this from the central pupillary light reflects to the upper eyelid margin in the primary gaze. When we will throw the light by torch, the reflex on the center of pupil to the distance between the upper eyelid or upper eyelid crease. That is called the marginal reflex distance. Normally it is 4 to 5 millimeter. If the margin is above the light reflex, MRD1 has a positive value. Sometimes the ptosis is so severe that it will cover the light reflex also. In that case, MRD value will be negative. So in this picture you will see with the help of scale we will keep the 0 at the light reflex and we will measure the distance between this light reflex and the upper eyelid crease. So distance between the upper lid margin and corneal light reflex is a MRD. In mild ptosis there will be 2 millimeter of drop, in moderate 3 millimeter, and severe ptosis there will be more than 4 millimeter. Vertical fissure height is the distance between the upper and lower eyelid in vertical alignment with the center of the pupil in primary gaze. Normally it is 9 to 10 millimeter in primary gaze, should be seen in up gaze, down gaze and primary gaze. So this is picture you will see distance between two eyelid margins. And grading of severity of ptosis: 2 millimeter mild ptosis, 3 millimeter moderate and more than 4 millimeter severe ptosis. Then we will assess the levator function because it will again helpful in deciding the type of surgery. In cases of ptosis, it is determined by the lid excursion caused by the LPS muscle. Patient is asked to look down and thumb of the one hand is placed against the eyebrow of the patient to block the action of the frontalis muscle by the examiner. Then the patient is asked to look up and the amount of upper lid excursion is measured with a ruler held in other end by the examiner, and this is the levator function. Means first ask the patient to look down, then we will ask him to look up by putting your thumb on the eyebrow to block the action of frontalis muscle. तो जितना वो लिड को ऊपर उठाएगा that will be the actual capacity of the levator muscle. So normal it is 15 millimeter or more, that is called good. So normal 15 millimeter or more, good is 8 millimeter or more, and fair 5 to 7 millimeter, and poor when it is less than 5 millimeter. Then according to these we will decide the surgical aspect of the surgery. In ptosis, severe cases, in congenital ptosis, severe cases should be treated earliest because there is chances of develop of amblyopia. But if it is mild to moderate, then we can delay the surgery up to 3 to 4 years of age. The surgical types are the fasciella servata operation is called the tarsoconjunctivomulerectomy in mild ptosis with good levator function. In second is the levator resection in cases of moderate to severe grade of ptosis with good levator function, and amount of levator resection depend on the severity of ptosis. There are two techniques of this levator resection: Blasko-Vicks operation, in which we will go to the levator muscle by conjunctival approach, while in Haber-Bosch operation we will go through the skin approach. And third type of surgery is the frontalis filling operation, bro suspension, done in cases of severe ptosis with no levator function. If there is poor levator function, then what is the role of levator resection? In that case, we have to do the frontalis filling operation. In acquired ptosis, first we have to treat the underlying cause. Conservative treatment, especially neurogenic ptosis, we have to wait up to 6 months post ptosis. And in surgical treatment, the options are same as in congenital ptosis. Means fasciella servata operation, LPS resection, and frontalis filling operation when there is poor levator function. Thank you.